Welcome to this webinar concerning fetal exposure reporting and treatment amendments in Utah, sponsored by the Drug Endangered Child Committee of the Utah Substance Use and Mental Health Advisory Council. I'm Karen Buchi. I'm a professor of pediatrics and vice chair for the Department of Pediatrics at the University of Utah. I also serve as co-chair for the Drug Endangered Child Committee of USAVE. The Drug Endangered Child Committee has members representing many agencies that address issues of maternal substance use and their children. One of our goals of the committee is to partner with the Division of Child and Family Services to develop practice guidelines that are consistent statewide on how to address the issue of pregnant women with substance use disorders. The purpose of this webinar is to explain the new reporting statute regarding drug-endangered newborns and their mothers that resulted from the passage of House Bill 244 in the spring of 2020. We want to provide accurate guidance about child abuse and neglect reporting to healthcare workers and other professionals that work with substance-using mothers. This webinar is directed at a wide audience of stakeholders with the goal of having a consistent understanding of the new reporting statute.
Hello, I am Kyla Clark, a program administrator for the Child Welfare System. To get us started today, I'm just going to give us a short history on the evolution of reporting statute changes. A recent study has verified that state policies that take a punishment-based approach when working with pregnant women with substance use issues can result in negative consequences for both mother and the baby. From 2000 to 2015, the number of states that have these punitive policies has increased twofold, from 12 to 25. And the number of states requiring healthcare professionals to report suspected prenatal drug abuse to Child Protective Services or health officials increased from 12 to 23. Findings by a recent study show that policies that penalize pregnant women for substance use deter those women from seeking prenatal care were associated with lower prevalences of OUD diagnoses. This study highlights the importance of policymakers considering strategies that enhance access to evidence-based substance use disorder treatment for pregnant women and strengthen treatment engagement as they seek to improve outcomes for mothers and newborns affected by substance use in pregnancy. This is the approach that was taken in Utah to change the reporting statute, to move away from punitive approach and to create a system that focuses on substance use treatment and family support. During the 2020 Utah legislative session, members of the Drug Endangered Children Committee collaborated with DCFS and state legislators, specifically Representative Merrill Nelson and Senator Alan Christensen, to change the reporting requirements to put more emphasis on supportive, treatment-oriented approaches rather than a punitive approach when addressing maternal substance use. What does House Bill 244 change? As of May 1st, 2020, a healthcare provider who attends the birth of a child will only be required to report to the Division of Child and Family Services when the newborn child is adversely affected by the mother's substance use, a newborn child has fetal alcohol syndrome or fetal alcohol spectrum disorder, or the newborn child demonstrates alcohol or drug withdrawal symptoms, or the parent of the newborn child or a person responsible for that child's care demonstrates functional impairment or an inability to care for the child as a result of substance abuse by the parent or the person responsible for that child's care. During the session, another House bill was passed, House Bill 365, and what that impacts is regarding cannabis use. This bill modifies provisions regarding how cannabis use relates to DCFS's ability to assess abuse, neglect, and the best interest of the child in the child welfare system. Prenatal use of even illegal cannabis on its own cannot constitute abuse or neglect. It is abuse or neglect and may warrant DCFS intervention if there is a nexus between use or misuse with the caregiver's behavior that separately constitutes abuse or neglect. That means the use is impacting the parent's ability to get out of bed, meet the child's needs. Evidence exists that harm to the child due to the inhalation, ingestion, or introduction into the body. There is a threat of harm due to a chronic inhalation, ingestion, or introduction into the body. So the child is being repeatedly exposed to the THC. Medical cannabis does not on its own constitute abuse or neglect. It is abuse or neglect and may warrant DCFS involvement if there is a nexus between the use or misuse of and the caregiver's behavior that separately meets the grounds for abuse or neglect. Unless there is harm or unreasonable risk of harm, the use of medical cannabis products in accordance with the Utah Medical Cannabis Act by the parent or guardian is not contrary to the child's best interests. So how does this impact healthcare professionals? So looking at prenatal care, when a pregnant woman discloses her substance use to her healthcare provider, it is no longer mandatory to report that to DCFS when the baby is born, unless the concerns with the substance use and the mother's ability to care for the newborn persist or the newborn is considered to be adversely affected by that drug exposure. Calls to DCFS about pregnant women with substance use issues may still be made in order to get connected to supportive services. Before House Bill 244, we never opened a case. If you called on a pregnant woman, those calls dead-ended with us, and we were asking you to call us back at the time of the child's birth. With the passage of House Bill 244, we were able to get permission to share that information with the Division of Substance Abuse and Mental Health and the Department of Health. These agencies now reach out to these pregnant women and offer voluntary services to engage them prior to the child's birth in hope that use will be discontinued by the time the child is born. So far, since May 1st, there have been 80 women who have been involved in this referral process. So far, we've been able to get several out of domestic violence relationships. We have the majority connected to either parenting or drug treatment services. We've been able to help with housing, and we are seeing positive effects at the time of birth without needing a CPS investigation. DCFS responds to calls about parent-caregiver use or misusing substances of abuse upon the birth of the child. A healthcare professional with concerns about drug exposure of a newborn or the parent's ability to care for the child should still call DCFS. The case may be classified as either fetal exposure or child endangerment. And the goal of DCFS will always be to keep the family together whenever safely possible to do so.
Some distinctions between fetal exposure and child endangerment to review. For fetal exposure, professionals who attend the birth of a child and determine the newborn is adversely affected by the mother's substance abuse during pregnancy are required to report to DCFS. The statute also states that if the newborn is diagnosed with fetal alcohol syndrome or fetal alcohol spectrum disorder, the case needs to be reported to DCFS. The statute specifically details that if the newborn demonstrates drug or alcohol withdrawal symptoms, the case needs to be reported to DCFS. But a very important in detail that was added due to this legislation was the statement that newborns with withdrawal symptoms due to medications taken by the mother as legally prescribed without indication of misuse are not required to be reported. This applies to a mother who is legally prescribed methadone, for example, or buprenorphine for the treatment of her opioid use disorder, and who has demonstrated that she has been compliant with her prescribed treatment program. It also applies to a mother who is legally prescribed an opioid to treat a chronic pain disorder, for example. While the newborns in both of these situations are likely to demonstrate withdrawal symptoms, reporting these cases to DCFS is no longer required. Child endangerment designation applies to those situations when the nursery team has concerns regarding the mother's ability to care for her newborn and the safety of the home environment that may be related to this mother's or other caregiver's substance use, or any other concerns regarding the mother's parenting ability, like her mental health condition. DCFS can help with referral to support services. So these statute changes put more decision-making into the hands of the clinical team regarding whether or not the Division of Child and Family Services need to be contacted. These statute changes are a step in the right direction to encourage nursery teams to understand that DCFS is an important partner in assessing the safety of the home environment where the mother and infant will be living. Child Protective Services caseworkers from DCFS rely on the nursery team's observation behaviors, her disclosures of her situation that are of concern, and any drug testing results to make a comprehensive assessment of the safety of the home environment of that newborn. This means that there is much less reliance on drug testing results alone. The focus is more on the impact of the mother's behavior and the risk it has for the home environment. We thought it would be helpful to present 3 case studies that represent common situations in Utah nurseries. This case involves a term infant was just born to a mother with a history of heroin abuse in the first trimester of her pregnancy. She entered a prenatal program and was placed on buprenorphine, which is an opioid used to treat opioid addiction. And she routinely attended her prenatal visits, and her urine drug screens during her pregnancy were negative for other opioids or other substances of abuse. Neonatal opioid withdrawal syndrome, NOWS, which is the more contemporary name for neonatal abstinence syndrome, is expected by the nursery pediatrician. So the question the nursery team has is, do they need to report this case to DCFS?
The answer to this scenario is no. According to the new law, a healthcare professional is not required to report withdrawal symptoms that are anticipated due to legally prescribed buprenorphine. In addition, the mother has been compliant in treatment, and the goal of the change for 244 was to encourage women as early in pregnancy to seek out treatment. So woman is done as we were hoping and in a best position to best care for her child, and there's no need to make the referral to DCFS. The nursery discharge plan for follow-up is especially important. Both the mother and the newborn need close follow-up in the medical home that can help the mother stay compliant with her treatment program and manage the newborn's withdrawal symptoms.
And I would also add here that although the nursery team is not required to report to DCFS, it is especially important to make sure there's a good discharge plan for the mother and newborn that can keep them connected and supported within the mother's treatment program, the pediatric care provider's office, the home visiting nurse, and other support services. Case 2 involves a woman who's been receiving methadone during her pregnancy for her opioid use disorder, and she just delivered her newborn. On review of the prenatal record, her urine drug screen from 3 weeks ago was found to be positive for opiates. She missed several of her prenatal visits and has not been fully compliant with her treatment program. In a recent visit, she demonstrated slurred speech and expressed concern that she may be soon losing her housing. Neonatal opioid withdrawal syndrome is expected by the nursery team because of the methadone exposure. In this case, does the nursery team need to report to DCFS?
In this case, the answer is yes. The mother's recent relapse, the continued noncompliance with treatment, the concerns about the slurred speech, and concerns about her overall functioning require assessment from Child Protective Services. We will be contacting you and get information from the nursery team about any concerns you're observing. So paying attention to behaviors that you can articulate well to DCFS will help us best assess what the next steps for this mother and baby should be.
I'm taking the opportunity here just to make a couple points about drug testing, and this is urine drug testing, especially in regard to opiate and opioids. Remember that opioid urine drug tests, it's only positive for drugs that the mother has been taking that metabolize to morphine or codeine. And to get a confirmation of heroin use, you need to also get confirmation from the lab using gas chromatography mass spectroscopy. But when issues of other opioids, so if you have concerns about fentanyl exposure or meperidine, which is Demerol, or methadone or buprenorphine, they do not show up on a urine drug screen as an opiate. They have a separate test involved. And so it's important to remember that while a mom who's on methadone, if her opiate is positive, that means she's been taking something else in addition to her methadone. Case number 3 is becoming more frequent in the last year for sure. A review of the maternal chart of a newly delivered infant reveals that the mother disclosed to her prenatal provider that she smoked cannabis a few times a week throughout her pregnancy. She does not have a state-issued medical cannabis card. The newborn is healthy with a normal exam. The mother is employed. She and her husband have 2 other children who are doing well. In this case, does the nursery team need to report to DCFS?
This case is a maybe. We would need to be looking at some of the child endangerment issues. You would want to do a good experts interview and have an opportunity to educate the mother about breastfeeding while using cannabis. This is where we see House Bill 244 and House Bill 365 overlap. We're really looking for that impairment of parenting. Things to consider talking about with the mother might be, does she plan to drive with the infant in the car under the influence of cannabis? That would be child endangerment. Discussing co-sleeping and the concerns that if while using cannabis you are co-sleeping with a child, it increases your odds of having infant death. Concerns about how much cannabis is using. Are we using to the point of passing out and not being able to meet the child's needs? If all of these answers are no, and there are no effects on the child, and the parents are present and can clearly articulate what they do to keep their child safe, a case may not be open, even if it is regular cannabis use and could even be illegal cannabis use. Without the nexus of abuse or neglect, DCFS can no longer respond.
We hope that you have found this information helpful in your work with mothers and infants affected by substance use. Thank you for your attention to these matters.